Hi, in this video, we'll be talking about randomized controlled trials, otherwise known as RCTs. While RCTs are oftentimes considered the gold standard in medical evidence, it's important for one to be able to examine the conduct of the RCT in order to come to an assessment as to whether or not the findings from the study is trustworthy. In today's session, we'll be going through what entails an RCT, its strengths and limitations, examining the internal validity, which involves assessing how robust the methodology is. And then we'll be looking at the differences between superiority, non-inferiority, and equivalence studies, as well as a quick word on pragmatic RCTs and crossover studies. So to begin, what is an RCT? An RCT is an experimental study in which participants are assigned to one of two or more clinical interventions. These participants are then followed up in their respective groups and analyzed for their intended outcomes. So the key components of an RCT include firstly that of randomization. And randomization, when conducted well, will control for both known and unknown confounders. RCTs involve the use of a control that oftentimes take the form of placebo or the pre-existing standard of care intervention. And having a control arm allows for direct comparison between the intervention and that baseline control variable. In terms of blinding, this involves ensuring that key stakeholders like the subjects, the treatment providers and study investigators do not know which arm of intervention or control the subjects are placed into. And we'll talk about the importance of it subsequently. And finally, whether or not the study is of a superiority, non-inferiority, or equivalence in nature. So when one is asked to describe what the design of the RCT is, these are usually the key components that are factored in. So moving on to the strengths and limitations, most of the strengths of an RCT come from the fact that it is an experimental study in nature compared to cohort studies or case control studies that are oftentimes observational. So the fact that it is an experiment allows for a few key interventions like number one, randomization, that powerfully controls for both known and unknown confounders. When we control for confounders, oftentimes in observational studies, we are usually only able to, using statistical methods, or limiting the population that is being studied, control for known confounders. There is also ability for precise control over the intervention. So let's say when we are giving a certain medication, we can control the dose, we can control how frequently patients take it, and oftentimes patients are also monitored very closely in this process. There is also certainty that the intervention will actually precede the outcome. And this is something that is important in establishing causal effects. RCTs also allow for the study of more than one intervention. So multiple interventions can be examined at the same time. And the use of blinding, which is oftentimes employed in RCTs, reduce bias through various means that we'll talk about later. There are, however, certain limitations. One of which is that RCTs are oftentimes expensive, logistically, administratively challenging to conduct. They are also not so ideal for rare events or events that take a long time to occur. So for example, when studying some of the perhaps side effects or adverse effects of certain medications that may take a long time to occur, RCTs, given the nature of its conduct, are oftentimes not so ideal. Because of its strong internal validity and because oftentimes RCTs have very stringent criteria, this may sometimes affect the generalizability or the external validity. And the structured design can sometimes be unrealistic relative to real-world practice, and this may come in the form of the excessively close monitoring or certain elements of the study that are intended to ensure the strong internal validity, but when it comes to real-world practice, these things may not oftentimes be practically deployed. And sometimes RCTs can be ethically problematic to conduct. So for example, one wants to study a potentially carcinogenic exposure, the conduct of an RCT for such a clinical question may be ethically inappropriate. So when we look at the internal validity of an RCT, these are the 6 key components that we need to examine. Firstly, randomization. Secondly, allocation concealment. Thirdly, blinding. Fourthly, the baseline characteristics that are oftentimes reflected in Table 1. Fifthly, the follow-up. And sixthly, the analysis protocol, whether it's intention to treat or per protocol. We'll start with randomization. So what is randomization? Randomization is a process of assigning participants to treatment groups in a random fashion. So the rationale for randomization is to control for both known and unknown confounders by ensuring that subjects entering into a study ideally have an equal chance of being allocated to any study group. As we go through the different types of randomization, we will come to realize that given the different types of methods applied, the chances may not always be equal, but with the different methods of randomization, the idea is that there is a degree of randomness that is attributed into this process so that any systematic differences across the study populations will be minimized. There are 2 big approaches. The first is fixed randomization, in which the randomization methods are defined at the beginning and allocation sequences are set up before the start of the trial. Versus adaptive randomization, this is a process which, strictly speaking, isn't really random in nature, but the randomization process is adjusted along the way to minimize imbalances that occur as the randomization process or assignment process is carried through. So we'll start talking firstly about simple randomization. So simple randomization can be done either using a flip of a coin, a random sequence generator, and simple randomization is the instance where true randomization is actually performed. So this is usually ideal when studies when the population size is large. However, in small studies, sometimes what may result is that of unequal group sizes just because of chance or unequal distribution of possible important confounding factors. And because of this, we sometimes see other methods such as block randomization, stratified randomization that intended to overcome some of these problems with simple randomization. So what is block randomization? In block randomization, subjects are placed into blocks and the randomization takes place within these blocks. The intention is to ensure that there are equal numbers or close to equal numbers of patients in each arm. And this is especially pronounced in smaller studies. Let's say you have a study of only 50 subjects. Just by chance, if we allowed for simple randomization, you may have a significantly unequal number of subjects on both arms. The problem with block randomization is that allocation concealment may be compromised. The way this happens is, let's say you have patients who are grouped into blocks of 4. Once you have randomized your first 3 patients, the treatment assignment of the last patient may hence be known because of this. So a way to get around this sometimes is to use different block sizes in different sequences, and because of this process, then this may circumvent that problem of the compromise of allocation concealment. Stratified randomization, on the other hand, involves dividing patients into predetermined strata, and these stratas are oftentimes based on certain key characteristics that are anticipated confounders. So for example, patients may be stratified into study centers, age, disease severity. The problem, however, is that if there are multiple important characteristics, especially in smaller studies, it becomes impractical to stratify patients multiple times because when you have multiple substrata, the analysis becomes challenging as the overall power is then compromised. Cluster randomization is a process where patients are randomized at the level of a unit of a cluster, and this is oftentimes the test center or the study center. This is commonly used in public health or primary care research, where there is concern for this problem called contamination. So oftentimes in public health research, where you may do certain interventions like using posters or educational videos that are aired in the clinic, it is challenging to assess the effect on the individual patient because patients who come into the clinic will necessarily be exposed to an intervention. So because of this, patients are then clustered into these different test centers and the analysis takes place at the cluster level. A problem, however, is loss of power because your unit now from the individual becomes the entire cluster. Clusters may differ in sizes, they may also be systematically different, and hence comparison across the different clusters may hence be fraught with problems of confounding. And finally, minimization, which is a form of adaptive randomization, is a process where patient allocation is performed to maintain similarity across predetermined factors. So the next patient, that is the assignment of the next patient takes into account what the baseline characteristics of the already assigned patients are, and the assignment of the next subject will then aim to minimize the characteristic differences across the various groups involved. Sometimes minimization is used in an absolute form. Sometimes it is paired with a degree of randomization that helps to imbue that important randomization factor that we want in order to sort of control for both known and unknown confounders. However, because of this process, problems will include that of introducing systematic biases, and because that randomization element will be significantly less pronounced, one loses the ability to control for unknown confounders, where one focuses very much on the known variables. So allocation concealment comes next. Allocation concealment is that process of ensuring that the randomization sequence is kept hidden from the individuals who are involved in the conduct of the study, particularly recruitment of subjects. So why this is important? As you can imagine, if let's say I'm someone who is involved in the recruitment of subjects for a particular study, and I am aware that the next assignment is, let's say, to the intervention arm, the tendency may then be to cherry pick patients who may have a favorable, potentially favorable response to the treatment. Hence that knowledge of the randomization sequence is a piece of information that should be kept hidden from those involved in the recruitment process. The rationale at the end of the day is to preserve randomization, because as you can see, if let's say I'm the recruiter and I decide to come up with a reason not to include the next subject because I think he'll be a poor responder to the intervention, we then will result in recruitment bias, and the patients who are recruited into both arms will be systematically different. In terms of methods wise, we tend to look out for certain keywords like number one, either some kind of central randomization where the recruiter has to contact a central method center or through a secure computer system only after the patient is enrolled, or sometimes sequentially numbered opaque sealed envelopes are used in this process. So next we talk about blinding. Blinding is a process where key stakeholders like the participants or subjects, the doctors, nurses, healthcare providers, or the investigators are made unaware of the assignment of the patient or subject to the treatment or control arm. The importance is to eliminate bias that could result from the knowledge of treatment assignment. This could take place in different forms. For example, from the point of view of the subject or the patient, let's say knowing that you are on an intervention arm may then perhaps affect the way you perceive your actual treatment outcomes, especially if these outcomes are subjective, or it may even alter your health-seeking behavior. So let's say you're on the control arm and you deem it as perhaps less superior, you may then go and take additional health-seeking or rather take additional medications to help to minimize any detrimental health effects. In terms of the components, as we mentioned, we look at whether blinding involves the subjects, the providers, and investigators. So a study can be single-blinded, double-blinded, or triple-blinded. An open label trial refers to a study that the intervention arm is actually, the intervention is actually made known. And this oftentimes come in instances where blinding can be challenging. So for example, when the treatment and the treatment and the control involves medication given via different routes, or it may involve surgery. But while there are methods to actually blind, for example, using a double dummy method or doing sham surgery, sometimes because of these challenges, open label trials are instead performed. And in these instances, then the limitations of the study would be some of the biases that may result. After the randomization, allocation, concealment process, we often look at the baseline characteristics to see whether or not the baseline characteristics are firstly balanced across the intervention and the control group. If there is balancing of baseline characteristics, this usually suggests that the randomization is performed well and that allocation concealment was also adhered to. If we see systematic differences in Table 1, then we wonder whether or not there could have been a problem with the randomization or whether or not allocation concealment could have been compromised. So apart from looking at the balancing of characteristics in Table 1, I think the other two important things to look at when we study Table 1 is whether or not the relevant characteristics are captured. So whether or not there are potential variables that could be confounders, and we want these variables to be reflected in Table 1. And secondly, we also want to look at the demographic features. Is this an older population? Is this a patient with more or less comorbidities? What's the disease severity? And this will ultimately affect the generalizability when we attempt to apply the study to our patients. So this is an example of a Table 1 taken off 2015 sprint trial. So as you can see, this will usually compare the baseline characteristics of the intervention arm and the control arm. And then we will look at, okay, so for example, in this case, looking at the age groups, the comorbidities, we then be able to have a sensing also of what the patient profile is like. And finally, we also then scrutinize to see whether key important variables are adequately captured or reflected. Next, talking about follow-up. So I think there are two key components about follow-up. First, we talk about the adequacy of follow-up, which usually ties into the dropout rate or the loss to follow-up rate. So why is this important? It is important because if, let's say, a study was powered to measure a certain outcome and based on a certain sample size, and we have lost participants because of this reason, this could affect the statistical analysis based on the power calculation. Also, when we have patients who are lost to follow up or patients who have dropped out, when we actually do the analysis, sometimes it is important to actually do a sensitivity analysis where we sort of examine the worst case scenario. So let's say if we examine, let's say, all the patients who were in the intervention arm who dropped out, and we assume a worst case scenario of them, let's say, having development of the adverse, or rather development of an endpoint, let's say mortality. And if, let's say, the analysis of this worst case scenario changes the direction of the results compared to the initial analysis, then one would have to be particularly cautious about interpreting the overall results of the study. So this is one of the ways to assess whether or not the degree of dropout rate or loss of follow-up rate is problematic enough, right? If let's say we assume a worst case scenario and the conclusion that is drawn from such a sensitivity analysis is still in the same direction as the main analysis, then we are usually a bit more confident on the validity or the robustness of the overall analysis. Next, we look at the duration of the follow-up. Duration of follow-up is importantly taken into the context of what is the outcome that we are measuring, right? So if we are measuring something like, let's say, development of, let's say, renal failure or mortality outcomes, sometimes we do need longer time periods to see these effects happening versus, let's say, we are looking at development of a type 1 hypersensitivity reaction to a certain drug. These tend to occur over a short period of time, and a shorter period of follow-up may then be reasonable. Hence, having that biological sense of that time frame is something important when we assess the adequacy of duration of follow-up. And finally, we talk about the analysis. So by and large, there are two main ways to analyze results in an RCT. First, the intention to treat analysis, where subjects are analyzed based on the initial allocation assignment, independent of the treatment that they actually receive or whether they withdrew, whether they crossed over or whether they were lost to follow-up. Versus a per protocol analysis, where actually subjects are analyzed based on the actual treatment that they receive. For most RCTs, at least especially in the context of a superiority trial, we usually want to see an intention to treat analysis. Why is this so? ITT approach, importantly, it preserves the original randomization. And if you think about the per protocol analysis, once you have patients crossing over, this ultimately disrupts the randomization. And if we think about why we randomize in the first place, it's because we want to control for both known and unknown confounders. So if your analysis takes place in a manner that sort of reshuffles the original randomization groups, then we ultimately lose that benefit of the randomization, and then we run into problems with having to deal with confounders again. The intention to treat approach is also generally a more conservative approach because like patients may drop out or may stop taking a certain medication because they can't tolerate the side effect. And it's hence also considered a pragmatic approach because it is more reflective of reality. I mean, the main disadvantage is that it is usually considered less explanatory because if you want to map the sort of effect of a certain drug, or rather map the outcome to whether or not you actually took the drug, then the per protocol analysis is more explanatory in that sense. But because of the important factors of preserving of original randomization, the ITT approach also being more reflective of reality, in most instances, we will want to see an intention to treat analysis being performed. In the context of non-inferiority studies, which we'll talk about later on, we usually want to see both an ITT and per protocol analysis being done, and the reasons will be explained later on. So moving on to the differences between superiority, non-inferiority, and equivalence studies. So when we do a superiority study, we are trying to assess whether A, which is the intervention, is better than B, the control. When we are looking at a non-inferiority study, what we are trying to say is that A is at least as good as B, right? Within a predefined non-inferiority range. When we are looking at bioequivalence, we're actually trying to say that A is equivalent to B. So usually bioequivalence means that the effect sort of falls within that margin range, which usually has an upper and a lower tail. Whereas for non-inferiority, you only usually have the non-inferiority margin, which is sort of like a single tail kind of analysis. So a certain intervention may actually be non-inferior and superior at the same time, which we'll talk about later on when we delve more into non-inferiority studies. So when we perform superiority studies, usually this can be done in the context of placebo when there is no known good treatment, or when we want to show that a certain drug is better than the existing drug. But oftentimes we also do see non-inferiority studies being done, especially when the new drug that comes out may have certain advantages like cost advantages, perhaps as ease of administration. So one of these examples was when we were comparing the DOACs to warfarin. When they first came out, many of these studies that were actually done at the outset were non-inferiority studies to show that at least from a therapeutic point of view, the DOACs are at least as good as warfarin. And because they also had those additional advantages of ease of administration, reduced blood checks, more flexibility in diet, etc. Bioequivalent studies are usually done in the context of the approval of generic drugs when we want to show that generic drugs are as good as the branded or reference drugs. So just a bit more on non-inferiority studies. So statistical significance of non-inferiority studies is assumed if the confidence interval of the studied drug is not more negative than the non-inferiority margin. We'll illustrate this in the subsequent slide. So as mentioned, the non-inferiority trial is essentially a one-sided sort of study as compared to a bioequivalence where you say that the study effect falls within a certain sort of upper and a lower tail in the bioequivalence study. So the statistical analysis wise, as previously mentioned, both the intention to treat and per protocol analysis should be performed in non-inferiority studies. So the reasons why the per protocol studies should be done is because, particularly for non-inferiority studies, the intention to treat analysis actually favors the null hypothesis of non-inferiority if there is a very high crossover or non-compliance rate. So what this is saying is that if, let's say, there is a high proportion of patients who cross over to the other arm or were not taking the medicines, this, the overall effect that would be suggested would be that there is no difference, right? So because essentially what's happening is that the patients in the intervention arm are then moving to the control arm, and if you use an intention to treat sort of approach, then the overall effects would sort of tend towards similarity. On the other hand, we would usually still want the intention to treat analysis being done still, because as mentioned, it is at the end of the day important to preserve the randomization. So usually what we want to see is that there is corroboration between both the per protocol analysis and intention to treat analysis, and that both outcomes show that there is non-inferiority based on the pre-specified statistical margins. If, let's say, one or the other of the analysis show that there is failure to show non-inferiority, then one has to be cautious in interpreting the results. As mentioned, one can also then consider testing for superiority if, let's say, the non-inferiority margins are met. So this is going to be illustrated in the next slide. So as mentioned here, the dotted line here basically shows the non-inferiority margin, right? So anything that is more negative than the non-inferiority margin would be considered inferior. So we can see the bottommost indicator that shows that because the confidence intervals are more negative than the non-inferiority margin, that treatment will be considered inferior. In terms of the example, the fourth example that we see here that says inconclusive, once again, in this case, because the confidence interval, the lower end of the confidence interval is more negative than the non-inferiority margin. So in this case, we cannot conclude non-inferiority. So the entire confidence interval has to be on the right of the non-inferiority margin before we can conclude non-inferiority based on the analysis. So as mentioned, if we look at the top example of that says superior, so in this case, there is a solid red line that actually is the point of no difference. If the confidence interval falls on the right of the point of no difference, apart from concluding non-inferiority, we can then do a sequential analysis to assess for superiority, and conclusions for superiority can be made in this context. The reverse, however, does not apply. We usually do not do a superiority study, and if superiority outcome is not met, then go and analyze for non-inferiority. This is something that is usually not done. So it's usually in the direction where you first study for non-inferiority, and if non-inferiority margins are adequately met, then we can do a sequential analysis to study for superiority. So just a quick word on a pragmatic RCT. So as we had previously mentioned, RCTs oftentimes occur in ideal circumstances that aim to maximize the internal validity. And the problem with this is that if we aim to apply the results into our real life circumstances, we often find it challenging, and we often have questions, because if the study criteria or the study conditions were too constraining, then the external validity is going to be compromised. Hence, in a pragmatic RCT, what investigators sometimes tend to try to do is to resemble usual clinical practice. So, number one, this should be applicable across different settings rather than only in settings that can perhaps afford very, very high resource, intense use of resources. And oftentimes, placebo and blinding may be sort of avoided because of a consideration of pragmatism. But as we can see, then sometimes the internal validity gets compromised, or maybe some of the strengths, such as the removal of biases that come with blinding, also get compromised. So oftentimes it's a balance between the internal validity and external validity considerations. So this PRECIS tool is a tool that can be used to assess how pragmatic a pragmatic RCT is, right? So we look at factors like, okay, how was recruitment performed? What's the trial setting like? What kind of resources were used? How was the intervention delivered? How closely were participants followed up? So these are factors that sort of tend to reflect how pragmatic or how real world the nature of the study conduct is. And finally, just a quick word on crossover studies. So crossover studies involve subjects being moved between treatment, or rather intervention, and control groups. So essentially the subject may serve as his or her own control. So the strengths are that in crossover studies, that there is a reduction of the intergroup variance because subjects serve as their own control, right? So if subject A is going to be the intervention and control, the group variance is going to be reduced. And you can also have a reduction of the sample size, because essentially the intervention doubles up as the control. And essentially, if you think about it, when we are looking at potential confounders, if the subject is the same for intervention and control, then both known and unknown confounders will be controlled for, and perhaps in the most ideal fashion. However, the main limitation with crossover studies are that the concept of a washout period. So if you're dealing with treatments that actually take a long time to actually have effect, or have lasting side effects, or lasting effects of treatment, then crossover studies can be very difficult to conduct. So for example, if you give patients, let's say, certain medication, like let's say immunosuppressants that may have long-term effects, or even let's say bisphosphonates that may have a long-term effect on the osteoclastic and blastic activity, then studying these drugs in a crossover fashion may not be so ideal. Versus maybe, let's say, studying analgesia, for example, it may be possible to study medications with, let's say, a shorter duration of action in a crossover fashion. So I think while crossover studies may have certain advantages, oftentimes the washout period could be something that's limiting, and overall it is challenging to be done in treatments that have permanent or long-lasting effects. So hope that you found this session helpful in terms of understanding randomized controlled trials better. Thank you.